So just to elaborate, Dr. Anita, I'm very thankful for such a kind and lucid introduction. I'm also thankful to NRC and NMCN for rolling out this wonderful program, because like all of us understood from the prevalence of malnutrition in the world, India is harboring one of the sickest people across the globe. So I begin my talk with a father of medicine, what he quoted almost thousands of years back. A slender and restricted diet is always dangerous in chronic and acute diseases. So all of I wish you will become a true leader after the end of this course. And there are many things to learn in this nutrition curriculum. So briefly, what the aim of my presentation is to give you an elaboration on the important role of medical nutrition therapy. Remember, now we use the word therapy means it comes under a law. Any kind of therapy, whether it is antibiotic, renal replacement therapy, ventilatory therapy. So this is now what we want should be, under certain set protocol. So I want all of you to be familiar with the concept of medical nutritional therapy in general. All of you know that since this first a part of your educational module is on the cardiovascular disease, and it's we have understood since many years it has remained the leading cause of death worldwide, and therefore most cardiovascular diseases can be prevented by addressing lifestyle changes, which also includes very important part of that changes is the nutritional intervention. Appropriately speaking, if you want us to define malnutrition when we were students like you, what we understood malnutrition only when this patient became cachectic. And all of you know it's too late to do an intervention when patients are in such a advanced stage. So now malnutrition, what we define is whenever there is any inadequacy or there is a disbalance with respect to any macro and micronutrients. So it can be undernutrition, it can be overnutrition, and also it can be like in form of micronutrient deficiencies. All of you know that the commonest disease in world even today is the iron deficiency anemia, and our country is loaded with vitamin and iodine deficiency disorders. This was one of the famous publication first came out with respect to hospitalized patient from Dr. Charles Butterworth way back in 1974 from UK. And what he observed that height and weight were not recorded in majority of the patients. And close to 60% of patients after hospitalization, they lost more than 6 kilogram of weight, and 40% up to the patient had albumin levels more than 3 gram per deciliter. And all of you know that the level of albumin is a good prognostic marker with respect to the outcome from that particular disease manifestation. So Dr. Charles Butterworth define it as a skeleton in the hospital closet. You tell me which illness does not lead into malnutrition. So every disease, whether it is an infectious disease or if it is a digestive system disorders, cancer disorders, metabolic disorders, all kind of 80% of diseased population is at a risk of malnutrition. This is again one of a wonderful publication which came from Professor Dr. Tommy Sederholm from Sweden. And what they categorize the patient on day of discharge. In those patients who lost weight during the hospitalized, they term them as a PAEM patient. And those who did not lose the lean body mass, they define as a non-protein energy malnourished patient. And they followed this patient for 1 year, and what they found that the impact of malnutrition on mortality remained very high even after 1 year of the discharge. And therefore, it is very important for us to understand what are the pathophysiological cascade. So with respect to the cardiovascular disease, all of you know that there is a compromise in the oxygen delivery, alteration in the GI digestion and metabolic pathways, and there is an oxidative stress, which in nutshell leads to kind of release of inflammatory cytokines, and that all leads to decreased protein synthesis and increased degradation of protein. So there is a very peculiar metabolic response to the injury and illness in form of mobilization of muscle amino acids to provide glucose. And therefore, it is very crucial to identify such vulnerable people, because if you look at this wonderful publication from Dr. Long, which was published in Journal of Parenteral and Enteral Nutrition, and what we found that somebody who is undergoing a like appendicectomy, so there was a marginal increase in the nitrogen excretion. So general nitrogen for a healthy people, nitrogen excretion is 4 to 8 gram for 24-hour urine. And remember, it's a nitrogen. So when you want to convert nitrogen into proteins, you have to multiply it by a factor of 6.25. And somebody like a COVID sepsis, what we have noticed in last 1 year, the nitrogen excretion goes as high as 20, and somebody with a severe burns, it goes even up to 30, which is equal to almost 200 gram of protein. And all of you know that the 1 kilogram of muscle, they contain 300 gram of protein. So there is a loss of close to 500 to 1 kilogram of lean body mass per day in a patient who are critically ill. So identifying the malnourished risk in the initial journey of the patient is very crucial. And it's not only about a numerical value of body mass index, or there is a other important factors like unintentional weight loss because of number of reasons, or patient does not feel like to eat. Like we have learned in this COVID people that there was a significant loss of appetite. So all these people we can define at medium and high risk of nutrition, and some care plans should be offered to these people. But unfortunately, though the reliable and validated tools for screening are available, screening is not routinely practiced in most of the hospitals across the India, and therefore malnutrition continues to go unidentified. And the opportunity of an early intervention is lost, and therefore it is very beginning of this problem. So if you want, we can precisely tell it's a multifactorial right from the insufficient dietary intake. When you check the meals which are served in plates to the patient, more than 50% of the patient, they never complete meals offered to them. So there is therefore a lots of wastage of the food. And also there is an impact of disease, or maybe the intervention what we do to treat the disease like dialysis. So that all leads to hypercatabolism. So this is very important also to identify the factors which are existing at an institutional level. Like institution doesn't have any kind of nutrition policy, or there may be limitation in form of catering provision because of very select menu. And also there is a skilled people are available, not so available with frequently. If we come to all of us, that most of the healthcare professionals like physicians and doctors, we never ever received any kind of specialized training when we were a student for undergraduate and postgraduate. So you people are very lucky to have this course curriculum, and I hope that with good learning like this, we are going to improve the statistics of malnutrition in this country. And that we can learn from this studies which was published by Dr. Mears. It was conducted in Netherlands, and what they identified that they did a mandatory screening and dietary counseling of all the patients who were in the hospital. and also those who were in staying in a nursing home. All of you know that in foreign countries, lots of elderly people, they stay in a nursing home. And they compared these two group of people with those elderly people who were living in the community. So in whom they did not do any screening and any dietary counseling. And over a period of next few years, what they found that in those patients whom they did a mandatory screening and dietary counseling, the prevalence of malnutrition was very low over a period of next almost 5 to 6 years. So therefore, this can be appropriately addressed if we have a will to do so. Malnutrition in cardiovascular disease, all of you know, it leads to kind of complication in form of these patients. They develop very easy fatigue. There is a decline in the functional quality. So therefore, these people, they have all other kind of cognitive issues, and also the quality of life indices, they worsen. And even if we are not able to do the nutritional intervention, there is an ongoing hypermetabolic cascade that leads to cardiac cachexia. And once the patients are in cachexia, it is one of the most serious complication of chronic heart failure. And then it is a reversible state, and therefore we uh, generally lose this patient because of very high mortality. So therefore, it is good to identify these people, because malnutrition adversely affect the outcome in form of increased complication from fall, or maybe infection, or maybe a poor quality of life. And therefore, it is very important to address these issues. Apart from that, if you look at the economic consequences of not treating the malnutrition, so if hospital patients, they have an increased length of stay in ICU, increased length of stay on renal replacement therapy, ventilation, length of hospital stay. There is a high incidence of readmission rate after discharge, and there is a delays in returning home. If you look at the community patients who are malnourished, they more frequently visits to their family doctors. They have a more frequent hospital admissions, and that all in lead to kind of increase in the cost of healthcare. So it is appropriate to make a good department of clinical nutrition, and that it should be in a proper organized way. So moment patient is, they enter the hospital, they should be screened, and we should recognize the nutritional issue, and then we have to make a roadmap whether this patient can be addressed by an oral diet, or maybe we might have to take enteral nutrition. We predict that this patient is not going to eat for pretty few more days. And if by some means, if you are not able to use guts, then the parenteral nutrition becomes very important. And over and above, after doing the intervention, then you have to monitor, review, reassess, and then again do the same changes. So this is a, the cascade we will be entering and re-entering again and again. So this is very important to understand the nutrition care process. It's an ongoing process unless the patient's nutritional parameters become correctable. That was all about the importance of prevalence of malnutrition, pathophysiology, and about the consequences. Now the time has come to understand how can best we manage this patient. So the first thing and foremost thing is the early identification. As we understood, cachexia is too late to intervene. So we must be identifying all those patients, at the beginning of their sickness. And therefore, using lots of validated tools are available, which you will be able to understand after attending a series of lectures. But on a pragmatic grounds, we generally prefer to optimize all oral strategies, like, improving calorically dense meals, high protein meals. But if by chance patient is not able to meet 60 to 70% of the caloric target, then we take the help of oral nutritional supplement. And if that is not sufficient and patient again remains in a hypercatabolic state, then we take the help of artificial nutrition. We now call it tube feeding or parenteral nutrition. So all methods of nutritional deliveries are available, but we have to smartly choose any good method. Like this study from a Dr. Stratton from UK, and what they use, the oral nutritional supplement in a malnourished hospitalized patient in one group, that is in a orange bar, and the other group in the blue, they did not use oral nutritional supplement, and all those patients they were in a standard oral dietary care. And what they found, that there was almost 50% reduction in complications when you do the supplement the oral diet with a oral nutritional supplement. So planning a nutritional intervention, as we discussed, the first priority should be oral diet. If that is not sufficient, we give oral diet plus oral nutritional supplement. And if that is not sufficient, we move on to the artificial nutrition. So this is a algorithm for those patients who come to a hospital bed, and then we follow this algorithm. Like whenever there is a gut is working, that is the top priority. And enteral nutrition has lots of advantages because it preserves the gut integrity, improves the immune response to sickness, and therefore it reduces the incidence of multi-organ dysfunction syndrome. But if by any means, if you cannot use gut, like intestinal obstruction, paralytic ileus, GI intolerance, acid poisoning, mesenteric vascular thrombosis, or very high output fistulas, in that case, parenteral nutrition has an advantage over standard of care. So this is how you will be following the algorithm. You may switch from enteral to parenteral, parenteral to enteral. All kind of transition will be followed through the journey during the hospitalization. But then we notice lots of barrier at the institutional level, at the national level, because of the lack of coordination among the various group members of nutritional support team. So doctors should discuss with dietitians, physiotherapists, nurses, and then they should roll out a one good smart plan. If you look at the current scenario of the feeds which are served to the patient, literally like say tea and toast diet, juices and cereal water, I'm not sure how are we going to meet the energy and protein. So this is where it should be, meals, every patient they should relish. So meals should be culturally appropriate and very tasty. We should not be giving, staple food. If we are asked to consume that staple food, even we cannot consume it for more than 2-3 days. So this was a nutrition day survey done by Dr. Michael Hismeyer in a various hospitals across the patients. So there were a number of reasons they found that there was a decreased dietary intake. So if you want us to address the energy recommendation, these are for the healthy people, that 65% from carbohydrate, 20 to 35 from fat, and like 10 to 35% from the protein. But then in case of current dietary recommendations, say for example, now we call diabetes and heart disease, they have a common soil hypothesis, So we treat them as if they are having a similarities between all the patient population. So this is very important, which has been defined by the American Heart Association. This looks very nice on the graph, but when it comes to actually implementing bedside, then we will scratch our head that how are we going to convert this into the actual meal plan. So this is very important. We should be incorporating all diverse sources of energy, proteins, vitamins, nutrients, and lots of antioxidants and trace elements. So this is the summary of hospital diet which are served in an Indian population. but 52% of the patient, they do not take the sufficient quantity of protein and energy. So friends, the balance of good health always lies in a balance of good plate. So two-thirds of energy and protein, they should come from a diverse source in form of grains, cereals, pulses, fruits, vegetable, dairy products, and a rich sources of proteins. And therefore, this is how we will blend the meals for our patient. So malnutrition is a huge challenge, and it's not a job of one person. All of us, we have to collectively fight this dreaded situation. So I just want to end my presentation by quoting a famous sentence by Albert Einstein, whose philosophy, he believed that we cannot solve the problems by using the same kind of thinking we used them when we created them. Thank you so much.